Welcome and thank you for joining us today for the meeting of the New York City Health and Hospital Information Technology Committee. Today's meeting is officially called to order. Next on the agenda, I would like a motion to approve the minutes of the Joint Medical and Professional Affairs and Information Technology Committee meeting held on February 7, 2022.
So moved.
Thank you.
No.
I'm going to poll each member to have for the vote. Jose,
Yes.
Dr. Katz,
Yes.
and I also vote yes. So the motion carries. Thank you. We now have an action item. Or Kim, you wanted to do a presentation before we go to the action item, or?
We can kick off with the resolution first, Chairman.
Okay, so yeah, let's start with the resolution in that case. Thank you, Kim.
Well, thank you, everybody. Today, I just want to introduce myself. I'm Kim Mendez. I'm the Chief Information Officer at New York City Health and Hospital. I'm joined today by Borba Carrier, who's our AVP for Finance and Administration, Dr. Michael.
Kim, I'm sorry, but I don't know if the microphone is too far from you, but it doesn't.
Can you hear me better now?
Now we can hear you better. Yes.
Oh, I apologize.
Thank you.
I'll just restart real quick. Thank you very
That's
much.
good. Thank you.
Good morning. I'm Kim Mendez. I'm the Chief Information Officer for New York City Health and Hospital. I'm joined today by Apoorva Carrier, who's our AVP for Finance and Administration, also Dr. Michael Boughton, our Corporate CMIO, and Jeff Lutz, our Chief Technology Officer. We have one action item today. I'll read the resolution. Authorizing New York City Health and Hospitals Corporation, the system, to execute a 3-year contract with Derived Technologies, LLC, for services to maintain workstations on wheels and medical carts, with the system holding 2 one-year options to renew for an amount not to exceed $6,500,000 over the entire potential 5-year term. I will now, we can move to the, oh, there you go. Very good. I'll turn over to Jeff, our Chief Technology Officer, for our overview.
Good morning, and thank you, Kim, and thank you, members of the board. And so this morning I'm here to talk to you about the maintenance for our, we call our medication carts, as well as our documentation carts. And there's a picture of those there on the right, and the ones without the drawer. The ones with the drawers are our medication carts. The ones without are our documentation carts. And the maintenance that is provided through this contract is for all of the items that are not including the computer. So it's for the items like the drawers or any of the mechanical parts in and around for those items, as well as preventative maintenance on the batteries that are used to support these devices and you know, allow proper working order. So for these devices, we have approximately 3,000 documentation carts, 1,000 med carts across all of the facilities that are provided primarily by 2 manufacturers, CAPSA and Ergotron. And with the implementation of Epic and the ability of us now to provide wireless across the enterprise, we had the utilization of these carts has increased, and we have a larger deployment of them, allowing the clinicians freer availability to move across throughout and service the patients and do the documentation that they need to. We have developed this in the past. This has always been done with Derive, and it's a maintenance that we've developed over the past 5 years, leveraging an interleader contract. And its annual cost has been about $1.6 million. They do have technicians that do come on site and they will covers both the technician's time as well as any of the items needed to support hardware supported, whether it's through warranty or even if it's beyond warranty, they will still continue to help manufacture or maintain these as long as they are viable. Derive is an MWBE certified within the city and has been a partner not just with this, but through other projects throughout for the past several years. And given that these are provided by different manufacturers, you know, they do tend to, and they're smaller, and these are custom built. They do leverage partners like Derive in order to perform these services. So this is something that's very traditional across the industry. If you can go to the next slide, please. So the procurement summary that was performed, we sent directly to 11 MWBE vendors through the help of the diversity group within supply chain. We were able to identify other MWBEs that perform similar services across the city. So, and Derive was rated the highest out of all of the 3 proposers that had responded. Again, Derive is a certified MWBE, and they were rated satisfactory for their performance in the past. The new contract that we're asking for is $6.5 million. It's a 3-year contract with 2 1-year renewal options. So that would be a not to exceed over that time frame. If we can go to the next slide, please. So this is the timeline. We started in February and completed all of our evaluations as we went through and into March. If I can have the next slide, please. So the criteria that was used, again, an MWBE only certification. We did evaluation based on their cost, their proposal, as well as their experience in servicing these similar types. The evaluation committee was made up of individuals from the facilities, primarily, including nursing, that utilize these carts heavily and interact with the vendors today. So have direct experience with this, which was important to us to ensure that we provide good service for these individuals. Next slide, please. So again, we invited 11 MWBEs, 3 responded. So and Derive is a certified city and state MBE. Next slide, please. So in summary, we are looking to enter into a 5-year agreement with Derive Technologies to provide support for the current fleet of carts in a not to exceed of $6.5 million. There is a termination for convenience at the discretion of New York City Health and Hospitals. The agreement, though it covers 5 years, is a 3-year agreement with 2 1-year renewal options that are at Health and Hospitals' discretion to do the renewals. With that, I'll open the floor for any questions.
Thank you. And let me ask each one of the members. Jose, any questions?
I missed the part on who provides these services now.
Derive currently.
Right, okay,
They're the current incumbent.
okay, thank you. No questions, thank you.
Thank you, Jose. Dr. Katz.
No questions, thank you.
Thank you. I just want to note for the record that Karen Sanghilier is representing Commissioner Gary Jenkins. Karen, any
Yes.
questions?
No,
Thank you.
you're welcome.
I also don't have any questions. So I would like to ask for a vote. Jose,
Yes,
Dr. Katz,
Yes, thank you.
Karen,
So good, I'm fine, thank you. No questions.
no, are you voting in favor of?
I'm
the-
voting yes, I'm sorry.
Thank you, Karen. Feniansky also vote yes, so the motion carries. Before we proceed, I would like to amend, do a corrections for the record. The minutes that we approved just minutes ago reflect only the IT committee meeting held on February 7, 2022, not the joint meeting with the Medical and Professional Affairs Committee. I just want to correct that for the record. Kolisha, is there anything else that I need to do for the record?
No, that's fine. Thank you.
Thank you. Okay, sorry for that. I just wanted to make the record correction. So next, we will have the CIO report and an informational item from Ms. Kim Mendez. Kim?
Thank you very much. We can go to the next slide. Today we'll be providing an update from EITS just on some targeted areas. I would like to take a little pause on our goals, as well as we'll get an update on our clinical informatics area from Dr. Michael Boughton. I'll talk a little bit about our application learning and get a pulse on where we are with our data center migration. Well, we can go to the next slide. This looks like a slide that I've had up here before, but I will bring your attention that it is updated for 2022. Key things that we'll be addressing this year that are modified or new for EITS, and then throughout the year when we bring our updates to this committee, we will be focusing on particular ones of those. The first one is the data conversion best practice, which we have launched recently. Going down, which I'll speak a little bit about today under the infrastructure enhancement area, is the CMDB, which is for a sustainable structure. We'll talk more on that when we talk about the SMO, or the Service Management Office, which we have begun in EITS. Also, Mike will expound a little bit today on the conversation around telehealth optimization. And as I heard earlier in MNPA, we are partnering with Dr. Allen on our remote radiology program. So we could go to the next slide. I'm going to turn over to Dr. Michael Boughton.
Great, thank you so much. So what you're seeing here is the effective use of H2O, otherwise known as EPIC, how we brand it here at H&H. And what you're seeing here is there's an EPIC program called Gold Stars that basically evaluates if you have all the features on that are meant to help your doctors, nurses, and patients. And what this shows is that we actually hit level 8 this year, which puts us in the, firmly within the top 20%, or in the top 20% nationally of all EPIC customers. If you look over at on the right side of the screen, those are the other institutions that are at level 8. We are unique in that we're a public institution, and we are in this group, and that's, I think, a real achievement for us. If you can go to the next slide. This is also another EPIC program. So the first one, you think about the structure. What do you have on? And then honor roll is more focused on if the providers, nurses, and patients are using the product in the way that's getting the desired results. This was a really ambitious project on our behalf, and I will say I was very, very pleased that we hit this one. I think last meeting, there was some doubt whether we were going to hit it for this year, and we did. And it brings a whole bunch of positives. One of the positives is a financial incentive. We get $670,000 from EPIC for doing this. Another one is, frankly, just a feather in our cap. Once again, about less than 20% of EPIC customers achieve this level every year. But ultimately, I think, and the real benefit here is that our providers and nurses and our registration clerks really get a better system to use. And ultimately, our patients get better care. So I know, I think I've mentioned some of these before, but the ones that I just love to talk about are, we're really just transitioning away from just taking care of the patients that show up to seek care at our institutions. And if you're one of our patients and you haven't had your colonoscopy and we know how old you're turning, we're going to send you a reminder that you should maybe have a FIT test or another colon cancer screening. Same thing on mammograms. And that, that was part of the honor roll program, but making it operational, driving it into use and getting our patients the benefit was a real benefit here. And we followed nationally established guidelines to get here. I will tell you, there's a couple of things. So, you're seeing on the right side of the screen what we hit for the year. And there's a whole bunch there. I think it's 5 plus the eligibility. But I'm going to, for transparency's sake, I'll talk about the 3 that we did not hit. So there's the financial component and there's an infrastructure component that we frankly hit most of the benchmarks in, but not all of. And that was really recognized very early on that we weren't going to be able to do that. That wasn't part of our goals for this year. We improved in each of those areas, and it's something we're going to look at for this coming year. But one of the ones that we did go after this year was patient experience. And I think last time I presented that was, we had 3 items outstanding. One of which was when patients show up, there's functionality that they can just let the registration team know that they're there without going to the registration desk. That's going on this month. There's another one that if you see your primary care doctor and you want to be seen next week and there's no appointment available for 3 weeks, we can put you on a wait list and we give you a text message or a Mychart message if an appointment opens up. That's also going on this month. So I'm very happy to report back on those two. The third piece was really a challenging one that we're still working on to this day. And that's our turnaround time on in-basket messages. So think of it this way. So a patient has a question, they write to their provider. How long does it take us to get back to that patient? We've moved from, responding within 48 hours is the goal here within Epic. We've moved from about 50% to 60% this year. So there has been real movement. I don't think anybody, and this goes from ambulatory to IT to everybody, agrees that 60% is where we want to be on this. This is a cultural change that we need to drive through. There are technical things that we have done and will continue to do to make this process easier. But I want to just transparently lay that all out here. And the whole point of honor roll is not to, it's not really the money. It's certainly not recognition. It's to draw attention to where we can improve our system. And I got to say, it did that and did that very well. So this is the conclusion of this year's honor roll. It's usually it's always a 13-month initiative. It's an Epic program. We will look at exploring this again probably later this year. But for the time being, we hit the first level of honor roll and got a pretty substantial financial incentive. And we're very happy for what it did to our system, for our system. I'm happy to take questions on this as we go or after I'm done, but you can keep going to the next slide. All right, so this is our biomedical integration initiative. So what this is, and you can see the lines here, the orange line is what our revised target goal for the year was to integrate new devices into our system. So think of anesthesia machines, cardiac monitors, spot vital sign machines, so that doctors and nurses and our patient care associates don't have to manually write down information and then from the monitor and then walk over to the Epic and hand peck it in. It's a way that the information automatically flows from the machine into Epic and is verified by a provider inside of Epic or a clinician inside of Epic. Big time saver. I think it's a bit nice from a patient safety perspective because you're not having transcription errors. And also it's affording our staff the most up-to-date timely information. So what you can see, the dark blue line are the net new devices that we integrated. This is putting in an integrated device where there was never an integrated device. And then the light blue line, which became a much bigger part of what we were doing, was taking devices that were already integrated, upgrading them and reintegrating them. So the way I like to talk about this one is like you have a cardiac monitor that doesn't have end-tidal CO2, which is very important for procedural sedation and monitoring how well they're breathing. And if we give it that functionality, that would be in that light blue line. It was already integrated before, but you're adding in enhanced functionality. So once again, this was our goal for 2021. We met our revised goal, and I think this is another successful project. We'll go to the next one. Mychart activation. So we've talked about how well we've done on Mychart over the years, and I have a slide in a second that I'm excited to show you. Right now, for activation rate among our patients, we are firmly in the top 10 percentile nationally among Epic customers. We're at 72%. The Epic median's right around 50. It's slightly less than that for public institutions, for safety net institutions. You can go to the next slide. Yeah. What I wanted to show you here, so we're at 72%. We haven't had we're in the 60s at the beginning of the year, but I wanted to take you back a little bit, a couple years, and you can see the curve. We were at 9% when we started. In December of 2019, we were at 13%. And then you see this absolutely huge growth of Mychart activation. Part of that is COVID, right? To be completely transparent. Part of that is our patients were getting their results from Mychart, and we're happy that they engage in this way. but this was true nationally as well. This was true for the other New York City hospitals. Our increase was just more than other groups' increase. You know, when you look at, this is all comers, all patients. When you look at patients who have a primary care physician within New York City Health and Hospitals, it's even higher than this. The number goes up into the 80s. I think the Mychart activation rate, we've succeeded on. I think what we're going to focus on going forward in collaboration with our ambulatory colleagues, with the Mychart steering committee, is depth of engagement and expanding access to Mychart to other languages than just English. Natively within, you can go to the next slide. So this is when I talk about depth of engagement, this is how often patients are logging in on a yearly basis. I think last quarter when I presented here, we had gone from 5.3 to 6.5, and I said, I think it's statistical noise, don't get too excited. We then went up a little bit higher and fell a little longer, a little bit. I think same answer. I think this is statistical noise at this point. I want to drive engagement, and there's things that we're doing to move this forward. One of which is something called Care Companion, which is a way for our patients to engage with us in an educational manner. So if you have a patient who's pregnant and you can give them a care companion focused on pregnancy health, and it will show them at different stages in their pregnancy how large the child is, what nutritional components are important. And this is something that we're developing. And Epic really didn't have this. Well, they have this in English, but they didn't have it in any other languages. And that doesn't work for our patient population or New York City Health and Hospitals. So we're developing that first in English and Spanish as a first step, and we'll look to expand it past that. Go to the next slide, and this is where we're talking a little bit more about equity. Last month or last quarter, I was asked which languages we have Epic in. And right now, natively, the languages that are important to us are English, Spanish, French, and Arabic. That's what we have today. What I'm sharing with you, and this we developed, that's natively from Epic, the vendor. We developed Simplified Chinese. And so that's what you're seeing here, is that a patient can log in, they can choose what language they want to see the Mychart content in. And we're going to keep going on this path. So Bengali is on our list. We have we're working with our diversity inclusion colleagues to see what should be next. You know, Mychart is an absolutely fantastic product, and we want to make it available to all New Yorkers that are our patients. And part of that is we're going to need to lead the way on this, because Epic is not going to provide us the content because nationally, these patient populations are not as large as they are here at New York City Health and Hospitals. So we're going to have to do independent development to do this, and we're making that investment. And I think it just, when you talk about depth of engagement, how we're going to get patients to log in more and have this be their source of truth, we need to meet them where they are in the language that they feel most comfortable using. I'll stop there.
The next area, thank you,
I
Mark, that's
wanted,
great.
Kim, if I could, to make one comment, which I think important for the board to endorse. In choosing goals, it's always important to think about what you're trying to achieve. And I want to commend you for focusing at this point on deepening Mychart as opposed to trying to get everybody on Mychart, which would not succeed. I mean, if you look at the sigmoidal curve, right, which is a very common curve, right? In fact, it would perfectly describe the COVID vaccination curve, right? That you have a period of uncertainty, then the news comes out, people want it, right? Then it shoots up when people see the advantages of it, but there'll always be a group of people for whom it's not the right thing, right? They're just not interested. And if you falsely sign them up or, twist their arm, they'll just never use it. It has no value. Getting near 80% is the right thing, especially given that many of our own patients may be a one-time person, right, who won't gain much advantage. But the deepening of it, and I would especially be interested as one of the metrics, not just the logins, but the number of times people are talking with someone. To me, that's a very valuable indicator of you're using Mychart. You're sending a note and someone responding. In a sense, those are, likely hundreds of thousands of interactions which never show up on our, productivity list, but they're very meaningful to patients when they send you a question and you answer it in a day or two, right? That really shows people that you care about them. And so I'd be interested as you deepen it to see more about, how much ongoing conversation we're producing through Epic. Thank you.
We can do that.
Yep. I mean, that is
Okay.
part of our patient engagement, metric. So thank you, Mitch, very much. Definitely.
Thank you, Dr. Katz. And I think since I think we are kind of naturally progressing from one topic to another, and Dr. Gordon is here, maybe we can ask any question for Dr. Gordon before we proceed. Kim, is that okay with you, Kim?
Oh, certainly, yes.
Okay.
Absolutely.
Jose, any comments or any question about Dr. Gordon's presentation?
On the comment on how fast things get answered on the
Yep.
basket, you said it went from 50 to 60%.
Yep.
How does that compare to other systems, if you happen to know?
No, yeah, we're less than other systems
Yeah.
in this area. Yeah, we are. The Epic threshold for hitting the honor roll status is 75%, 75% are answered within that time frame. Yeah, we are below average.
Do they
in that
have
setting.
work groups or anything like that that allows you to get some ideas on how?
Yeah, thanks. So yes, we do. So this has been identified as a problem for a very long time within New York City Health and Hospitals. We have something called the Mychart Steering Committee, which has ambulatory leadership or ambulatory care leadership on it. I sit on it. There's, it's a big collaborative group. Patient engagement is on there as well. And that's been one of our metrics for the past year and a half or 2 years. What is new here is we've asked over the past year, I'd say, we've had site-specific Mychart steering committees set up, and each of those have a project improvement initiative. And I think I don't know the numbers right off the top of my head, but I believe it is 8 of them have 8 of our sites have their initiative to turn that metric around. So yes, it is both known to be an issue. It's something that the group is working on deeply, and there's a lot of different solutions that are floating around. Right? So I can bring this back in the future and give you updates. But yeah, it's yes, it is taken very seriously.
Thank you.
Thank you, Jose. I just want to follow up on that comment, because what I have seen in systems is that they have kind of a layered approach. Like, for example, when you send the message, there is a kind of a first line of defense. If you want a first line of response, that's a better analogy. First line response. Like a nurse, if they can handle the question, like it's a refill or something. So it's not necessarily the doctor that see the patient, but there is one person first. And other cases is if the first line of response is not able to respond because it's beyond their purview, at least they respond and said, we are going to follow up with the doctor and follow up in a particular time period. And I noticed that helps people, because now you know that the message was received by a person, not like lost in the ether. Do we have those type of structures, and have we seen that helping out in the cultural change?
So we do have it's called a pool that the messages go through first. And the reason that they go there is if the message is for a prescription refill and the patient already has prescriptions on file, they can turn it around and do it that second. If it's a scheduling question, they can turn around and do it right away. The messages that go right to the provider is if you're already in a conversation. So if you write in the first time, it will go to that pool. And then each subsequent conversation, if it gets routed to the doctor, each subsequent conversation doesn't go to that pool. It just goes right to the physician or right to the provider. So I think that structure helps to tame the in-basket somewhat, to help it be less unruly for the provider to keep things out of their in-basket that really that they don't need to be the one taken care of, and allow them to operate at the top of their license. The other part of this is, it's the response to the patient. we talked about this one a lot in the group, and one of the things that we try to not do to our patients is to send them a message that doesn't have information in it that is immediately actionable. And that's the flip side of telling them what the time frame is. So what we did is we inserted a little banner saying what the expected time frame is for them to get a response and what to do if they don't get a response in that time frame. So that information is presented to the patient. And really, this is easier to say than to do. We need to just get back to our patients within that time frame. And I think that's the ultimate solution here. My fear is that if we start sending them extra messages that don't have anything to do, then when we do respond, they're going to be less likely to check it. So that's the current thinking, and I'm always happy to speak offline if you want to get into some of the more detail that we have on this. We got to look into what's our click rate when we send a message. Are they actually opening it or not? And we try to watch that very carefully, so we make sure that messages that they're receiving from us are high value.
Thank you. I think that's very good. I really appreciate how you are so transparent and clear on your achievements, as well as the areas that you wanted to work on. And I think this is very, very important. I just want to commend you and your team and Kim, the progress that you made on Mychart and the S-curve, clearly presents how things, of course, you wrote the COVID wave, but you keep going. So I think that really is something very, very important. The number of the equipment that were connected and upgraded, also a major achievement for your team. I just want to, again, congratulate you for all the accomplishment. And definitely, I understand that it's a team effort. So please send congratulations to everybody that has been involved. It really shows how much you care on your team north is ensuring that we are there to serve our patients. It's not the technology, it's serving our patients. And I think that comes through very, very strongly in your comments and your accomplishments. So thank you so much.
Thank you. I would be remiss not to share our former CIO's quote here that these are not IT projects; they're clinical transformations, and I think that's how we all look at this.
Yeah, and now that I'm in this point, I also want to thank Kim for showing that slide on how the work that you are doing connects to the larger strategic goals for the whole system. I think that's very, very important because it shows that everybody's working to further those goals, and everybody comes from different areas and doing different things, but always having that direction that we are always working towards. I think that's very important. And Felicia, I would definitely recommend that we share that with the other committees so that they contextualize their information and their work within that larger strategic goals that have been developed for the health and hospital. So thank you, Kim, for doing it in every meeting and keeping it updated. So,
Thank you very much. We're going to transition a little from, thank you so much, to our data center migration. I know we'll keep it short the next few minutes here on this. This is our enterprise data center migration. As we may recall, we have a project timeline that ran from May 2021. Our completion date is May 2023. We have currently 2 data centers that are at the end of life, and we are transitioning to 2 new data centers. Part of the work is being done in parallel, not to go through the entire slide, but Jeff and his team have done an amazing job in installing some new storage space at the new center, testing that space, beginning the foundational components of the first wave move, which we will be doing this month, which is very exciting for us at QTS, and also planning for Cyrus 1, which is our second data center, and that is in the pre-planning stage and preparation, and we are well on our way there. At present, at the end of the of April, we were at 38 to 40% complete. Our goal is to be at 50% complete by the end of May. We are currently on target and on budget, and thanks to Jeff's ingenuity, we have our supplies coming in from across the system. We've had some supply issues, as you can imagine, from a technology perspective. So kudos to Jeff and his team there. Want to move right into our Thrive. So Application Learning Department is the educational arm, if you will, of EPIC. But we have transitioned beyond EPIC into other clinical applications to support our system. We call that the Clinical Application Learning Department. After we had completed all of our go lives right before the pandemic, we then decided to begin our work on the effective use of our electronic health record, and we developed a program that is called Thrive Training. This is an area that is the content is developed based on tickets that we might receive across the system, stakeholder information, some of the new things that are out there that we needed to support from a regulatory perspective. Our kickoff of this program was actually to put together a workshop for the Joint Commission preparation for our system. Key to that is, having individuals who are at the bedside that utilize our electronic health record know how to do the chart review, navigate freely and comfortably in that, and this actual course actually supported that. In addition to that, Sean and Patricia Ruiz and team have actually put together a hospital billing work queue as well. We can go to the next slide. And then one new area for virtual training is this launch where we can provide one-on-one virtual training to our individuals across the system. One in particular it could be around an application, but also there is an area within EPIC where the provider can put together a personalization, for the electronic health record. And sometimes you might need a little support and navigation on how to pull that data in and make it really useful and easy to navigate for yourself. That is one thing that the application learning team can do as part of the Thrive program. And we have a link to, apply for that support, and the team will get back to you. So there's several different areas, and Mike and I and other team members have spoken about, dragon dictation and other things like that. So as we continue to learn lessons from our end users, we will continue to augment and provide additional training from this team. We can go to the next slide. I want to close our presentation today to talk a little bit about our service improvement in EITS. We are beginning to offer a restructure within our service area to develop an office of service it's called a service management office. What this will do for us is to provide a shift from a more reactive or segmented structure to be one that's proactive, customer-centered, and service provider type of model. This is what I feel is a natural next step from a quality improvement perspective for our EITS organization. It will help coordinate all the system requests that we receive. This could be from the help desk. It could be from the demands or requests that we receive for new optimization. We receive and work on over 2,000 of those a year, and as well as all of the support that the Enterprise Support Services Desk provide us. This new office will really engage and manage the different activities for the end of the life cycle of all of our services. So when something new comes in, like an application, it comes into the project management office, we vet that through, and then once it has launched, it needs a new home to feed it and nurture it and maintain it. That is the service management office. One key area is that our team is working on, if we go to the last bullet on the slide, is bringing the different services together under one umbrella, which is the Enterprise Support Services. It is our knowledge management, our change control. Before any change happens in our system, we all take a pause with a group that's called Change Control to ensure that we have all the right pieces together. We avoid any unintended consequences, and then we move forward with that change across our system. Key to that is the Service Configuration Management database, which is the CMDB. Thank you for moving that forward. And this is really a dynamic database. It is core to everything we do across New York City Health and Hospitals. It helps manage our application portfolio, as well as it drives decisions from security and our data center migration as well. So I am extremely excited and pleased that we are moving forward with this office. Our number one objective is to actually improve our service to all of our end users. And I'll close there. Thank you very much.
Thank you, Kim. Here an echo for me. I thought that. Can you hear me okay or not?
A little.
Penny, you have an echo.
I don't know where it's coming from. I changed the microphone to see if it is better.
Yes.
Yes.
Yeah.
Now it works.
Okay, so if that works, that's good. Let me in that case open up the floor for questions. Jose?
No questions. Thank you for all the work. That's what I'll say. Thank you.
Thank you.
Thank you, Jose. Dr. Katz?
No questions, thank you.
Thank you. I just want to say, Kim, that I really like your last item, the informational item, because of the emphasis on continued improvement and really looking how to be proactive, because usually IT organizations tend to be the one that everybody complains about it, because they have a meeting that something is not working and they don't get it, fast response because they needed to do it at that point. And trying to get ahead of that, trying to ensure that everybody gets the same service and trying to ensure that you are looking ahead before problems happen and kind of hand-holding everybody. I think that's very, very commendable. So I just want to thank you for always looking ahead and ensure that IT is like water, It's like you don't know it's there, but whenever you open the faucet, it is there. So I think that is very good for your organization and your team. So I just want to send that congratulations for that thinking to all of you. So that is only my comment. With that, I think that if there is no other questions or items, any old business, any new business? If there are no further discussion, all in favor in adjourning this meeting? Yes?
Yes.
Yes.
Thank you. And you just got 12 minutes of your life back. So can you imagine that? So
Thank you, Fanny.
thank you,
Thank you.
everybody.
Thank you.
Thank
See you.
you.
Bye-bye, everyone. Thank you.